Once again, my name is Austin, and I just want to welcome you guys to the Study Club of Dallas. We have Dr. Kevin Kim, who will be teaching us today. The topic today will be the use of digital dentistry and surgical guides for successful implant therapy. Furthermore, I would like to inform you all that you may receive 2 CE credits. You must stay active during the whole session. And at the end of the webinar, you will also be receiving an email from GDIA with a survey link. Once you have submitted the survey, you can expect to receive your CE certificate by email within 14 days. We also have a Q&A session after the lecture. Without further ado, I'd like to introduce our speaker for today's seminar, Dr. Kevin Kim. He has received his undergraduate degree in psychology from the University of California, San Diego. He attended the University of Southern California to obtain his doctorate of dental surgery. Dr. Kim is a graduate of Coy Center, has completed courses on advanced bone grafting at the Pecos Institute, took a 9-month implant training program at the Misch International Implant Institute, trained in the use of Piro's block allograft, completed implant training at the Zimmer Institute, and completed an IV sedation course.
Hello, everybody. So let's get started. I am a general practitioner. I'm a general dentist, and I'm in a group practice, actually. So I work with 3 dentists. So this is where I work. It's called Dental Health Associates, and it is located in Lakewood, Washington. These are my partners, and the guy on top, he's my classmate from USC. And I guess one of the advantage of the being in the group practice is that we have better purchasing power. So because of that, it's about maybe 2006, I think. It was a CEREC. At the time, it was very, very fascinating to me. And then, so that's how I got into basically digital dentistry. And this is what I started with. This is CEREC RedCam. And I don't know whether you guys are using, any of you are using CEREC or not, but this is like, long time ago, like 12, 13 years ago. And back then it was not even the streaming. Is like it was a still shot. So you just take still shots of the teeth, and then we designed restorations from there. So it was pretty rudimentary, but and then we move on to a blue cam, which is a little better, but still which required powders, and it was still shots, not video. And then OmniCam, actually, so it's Prime Scan, but I meant to put a OmniCam picture. So OmniCam came around, and which was actually video, and it was in colors. It was a lot better. And then, as you know or may know, there's a Prime Scan, which is very, very, very good scanner. And these days, a lot of dentists are interested in intraoral scanners, and Prime Scan is very good scanner. Only downside I see is it's very expensive. If you want to incorporate that into like same day restorations, then the scanner itself is about $75,000, or if you just want to use it as scanner, then it's still like $40,000 or $45,000. So I just thought that Prime Scan is too expensive, so I was looking for the alternative. And my other partner, they bought he bought the Prime Scan. And so in our practice, we have, many different, like few different intraoral scanners. We still have OmniCam. Now we have Prime Scan. And then we had Trios, and which is this one, which is really good scanner too. Only downside is still the price. And then they have annual subscription fee, which is about like, I think, $2,000 a year. So that cost gets added to the whole, purchasing price, I think. I mean, you have to pay annually, not, upfront, but, there is the annual, subscription fees there. And then we have Medit i5. I have basically, instead of buying into Prime Scan, I just bought i500. And then, now I have it upgraded to i700. So I'm just curious, does any of you have intraoral scanners? Anyone? No? Okay. All right. Nope. Okay. So, I'm sorry. So I'm using i500, and then, so speaking of intraoral scanners, I mean, there are many, many choices out there. I mean, I mentioned and showed a few intraoral scanners, but, there are, you know, 3M, I don't think they make it anymore, but there's Trios there, Emerald, from Planmeca, and, there are CS, I think there's 3600 from Carestream, and then I know Carestream came out with wireless intraoral scanner, so that was pretty good. And Trios already has wireless intraoral scanners, and that's CEREC. So there are, and then there is iTero. So if you are doing a lot of Invisaligns, and then iTero might be the one you want to get. But the question is, I mean, intraoral scanners, are they really good? Can they replace conventional impressions in the PVS, or so that's the question I had when I was getting into digital dentistry. Um, so when you talk about accuracy, you have to talk about accuracy and precision. So basically accuracy is how close it is to the bullseye, right in the middle of the target. And then precision is that, I mean, if you hit the bullseye, you hit the one bullseye out of 10 times, then, it is not really good, because, you're missing 9 times out of 10. So precision is that how, consistent it is. I mean, if you use the intraoral scanner, and, when you scan like on this patient, it is really accurate. But when you scan on another patient, if it is not as accurate, then, that intraoral scanner is not consistent. So we have to look at the accuracy and precision. So if you look at these 4 different targets, as you can see, the ideal scanner would be on the lower right, hits the bullseye all the time. That would be the best scenario. And those 2 on the upper right and lower left, I mean, they're not good either, because, one on the upper right, has really high precision, but accuracy is really low. And then the target on the lower left, I mean, it has pretty good accuracy, but, it's not consistently hitting it. So we want to look for, or want to find the intraoral scanner with high accuracy and high precision. So when you think about, well, actually you have to know about the conventional impression materials and technique, how accurate, are they? So alginate, it's only about, 40 to almost 200 micron accuracy. And then our PVS impression, it varies from, 40 to 130 microns. So roughly the average is about 35, 40, micron accuracy that the PVS material we use all the time has. So can the intraoral scanners match that accuracy? So this is a study done by the University of Zurich, And then, it was, I think, funded by, Dentsply Sirona, which makes CEREC. So I put this, graph here, not because it is really accurate, but I wanted to see, I mean, so this is CEREC. And then, of course, Dentsply Sirona wants to sell CEREC. So they want to make sure that, they look really good on this graph. But what I'm interested in this graph is the numbers of the competitors. If you look at other competitors, the TrueNet's Precision, for CS3600 is about 60. iTero is about 60 also. Medidye 500, back then it was, 90. Omnicam is 90. If you go to Trios, that's about 50. And this study was, published, several years ago, maybe 4 or 5 years ago. So, I mean, since then, technology has advanced, so much. I mean, I used to use i500, like 2.5 years ago. When it first came out, it was, kind of mediocre, intro scanner. I mean, it has a really good, price point. So it kind of disturbed the intro scanner market because of its price. Because I think that was the first intro scanner that broke the $20,000 price, price line. But since then, Medit came, out with, numerous software updates. And the scanner, the same firmware, the same scanner got better and better with the software upgrade. It's kind of like, I didn't know about this, but I found out that, Tesla, if you want to increase its, I guess, 0 to 100, mile like speed or acceleration, I mean, do you know what you have to do? It's not like changing parts or, upgrading any firmware. If you upgrade the software, then it's gonna, have a better acceleration. So software, plays really a big role. So my point is just looking at this numbers, published by the CEREC, I mean, you can still see they have very decent accuracy. And given that this, like I said, this study was, published a few years ago, these days, I mean, like Medit i500, they're saying that their accuracy is like less than 10 microns these days. I mean, I would not, take their words just without questioning it, but I can definitely say, it is better than before. So I will not be surprised that their accuracy and precision is, around maybe 30, 40 microns, which is very equivalent to the accuracy of, PBS material. So the consensus these days, digital impression or intraoral scanners are as good and accurate as conventional impression. So I don't think there'll be anybody who would say intraoral scanner is, very, very inferior. So I want to make sure that everybody understands that intraoral scanners are, very, very practical and is very, very, very good. So when it comes to, digital workflow, there are some steps. So you have to acquire digital data. And then with that data, you have to design. So CAD stands for computer aided design. And then once the design is completed, you have to manufacture that, so CAM stands for computer aided manufacturing. And then there's a manufacturer. It's kind of a little redundant, but I put CAM there because there is, CAD software and there is a CAM software. And in manufacturing is actually making something. So when it comes to, say, CEREC or like same-day crowns or restorations. So how you acquire data, you use intraoral scanners. And then there is, CAT software, and there is, CAM software. And, for example, CEREC, it is basically milling, which is a subtractive manufacturing mode. So let's look at this case. So it's number 30. Got the little large, DO composite, and got some distal buccal cause fracture. So we decided to do a crown, the same day crown. And these images are taken with the Medit i700. So we need to acquire the data, basically take the digital impression. There's a little video of how it was captured. I'm not the, like best, person to, do the scanning. But, scanning is also is a technique. You have to kind of learn and, master. I mean, when I first got into digital dentistry, I mean, I thought that, just buying these equipment will just, give me the great results, but it wasn't the case. You have to learn, you have to practice, and you have to get better at that, So, so I'm just capturing the opposing quadrant. And then I'm gonna take the lower right quadrant where number 30 is. So this is a pre-op. And then I've seen people out there who can scan like full arch, like within 30 seconds. And I can't really do that. I mean, it takes me at least a minute to scan a full arch, sometimes a little longer, sometimes a little less. And then this is taking a bite. Yeah, so all green means that it is a good capture there. So that's the acquisition of data. And then here, I'm just cropping out the number 30 because I want to replace that portion with the prepped images later on. So one of the advantage of digital is that you can, there are a lot of tools we can use. You don't have to take digital impressions all the time. You can, these will be all saved, and then if the same patient comes back later on for other teeth, then you can still use the same images. You can just kind of crop out the areas that you're going to be working on. So this is the prep, after prep, and the software pick up, where you started, and then now number 30 has been prepped, and then this is kind of like online type of a crown. This is basically adhesively retained crown, and then scanning, make sure that I get every detail, especially on number 30. Now we're going to have to design a restoration. So that is CAD, computer-aided design. And I use exocad. So when I was using CEREC OmniCam, everything was done in CEREC, but like I said, I didn't want to invest in prime scans. So I was looking for alternative. So instead of using, CEREC, like I said, I used, Medit i700 to get the scanning, to scan the teeth. And then I'm going to design a restoration in exocad, which is a software. I mean, there are different software out there. There's exocad, there is a Dental Studio from 3Shape, and then I think Blue Sky Bio has. I mean, there are a number of different CAD software, but I use exocad these days. So I basically brought those scan files into exocad, and then I'm going to design a restoration here. And these are really good images. And then, I mean, bytes is pretty dead on there. I mean, before with i500, sometimes when you take the bytes, you know, occlusion would be off. But with the new upgrade and the new intro scanner, I mean, byte is very, very good these days. And this is just defining the margin. So one of the benefit of making your own crown is that, you know, you have to prep and you have to have a really good margin, because when I design my own restorations, if the margin is not good, then I would have a hard time to find the margin. So if you can't find the good margins, then the restoration is not going to be good. So I mean, I had to work hard to get, you know, better margins. I mean, this is not the best margin, but, you know, at least I can see what the margin is. And then when I get crowns, when I see it, actually margin adaptation is pretty good. So after margination, move on to the next, and then basically there are like so many different, you know, tooth library. So it's going to give you, you know, proposal, and you can choose different tooth library if you like certain anatomy of, you know, certain library, then you can change. I usually stick with the generic one anyway, and that's the proposal. We have to kind of move the proposal around to make sure that it is in a good occlusion, in a good bite, in a good relationship with adjacent teeth, and with opposing, you know, opposing teeth. We're gonna kind of fine tune the position there. And then I didn't like what they gave me, so I kind of went back and, you know, little trick kind of, you know, moved it up a little bit. I know it's gonna be all the red marks means that it is a hyperocclusion, but I can adjust that, you know, in the later stage anyway. So, and that way at least I get a better anatomy. Kind of fast forward here. So that's that. We're fine tuning the occlusion a little bit. Okay, so once design is done, then you have to send it to a software, which is a CAM software. So, I mean, sometimes it could be confusing because there are so many software. I mean, there's a software when you scan the teeth, and as you saw, there's a software that you need to design restorations, and, you know, there is a software that you're gonna construct a file to mill restoration in a milling machine, basically. So there's a CAM software, and in this case is a CEREC InLab. So this is CEREC InLab, which is CAM software. So just the place the already designed restoration in materials, basically, you know. So CEREC uses blocks, so it's gonna nest a designed restoration in the blocks of your choice of your material. And in this case, I used the EMAX, you know, lithium disilicate. Okay. go. So I'm basically importing a uh, design file. So that's the design. And I know there is little weird anatomy there. It's because the material is a little thin. So that's I'm going to adjust in the mouth, or maybe I just did it when I polished it. And then you may be concerned that it might be a little too thin, but I know it's okay because it will be right against the enamel. So when it's on top of the enamel, it could be a little thinner, but still strong. So this little square, the box, is a block of Emacs, and I'm just nesting my restoration. I mean, it's just you just want to make sure that your restoration sits right in the middle of the block. That's all you have to do. And once that's done, with the software, there is a wireless connection to the milling machine, and you can just send it to the milling machine, and the milling machine is going to mill this restoration. So that's the manufacturing. So we have a MCXL, the CEREC milling machine, and then that milled this restoration. And it's in purple because it needs to be glazed, because if you're trying to mill the lithium disilicate, it is too hard, so it'll take too long, and then it's gonna wear down the burrs really fast. So this is kind of like green state. So it's still hard. It's very hard, but it's not as hard as the final the lithium disilicate. So this is how it's milled, and that's the milling machine MCXL. And then I kind of tried it in the mouth, and then I glazed it. So I have the oven, which the whole thing, it takes about 20 minutes. And then I had some little the what's that, the Unisem little cover the dentin to reduce the sensitivity, and etched the enamel ring, and added bond and cemented the restoration with the Link, and excess is removed. So that's basically what I do when it comes to single restoration. If it's like bridge or implants and that sort of thing, I still manufacture them in-house, but it's not going to be the same day. I use different milling machine to mill zirconia. But that's pretty much what I do when it comes to daily dentistry. But if you're talking about implants, that's the workflow is still very similar. It's about the same. So I don't know whether any of you remember this. It's 1998, and I'm sure most of you were born. But I came to United States. It was in 1989, and then I remember this, map book. And then, so if you want to go somewhere, you have to look at the back of the guidebooks, look at the city, street number, and then it will tell you which page you have to go and turn to the page, and that's how we got from point A to point B. But these days, nobody uses this maps anymore, because we have GPS, and and everybody has GPS on their phone. So we use basically this, traffic guide. So same thing with implant dentistry. We have to use some sort of guide to place implants, because when you think about implant dentistry, all you think about is surgery. That's how I was too. When I first taking implant courses, I was like, I was thinking about bone, I was thinking about tissue, bone grafting materials, and surgical techniques and suturing, incision design. It was all about surgical. But as I do more implant dentistry, actually it is probably more prosthetic than surgery. I mean, of course, surgery has to be done really right, but if you have really bad or poor restoration, even if you did a great surgery, the implant's not going to make it. So implant dentistry is the basically prosthetic discipline with a surgical component. And then prosthetic failures and complications happen more often than actually surgical complications. About 3.8 times more often. So let's look at this case. I mean, it's, as you can see, implant was not ideally placed. It is placed too distally, and this is my case actually. So I'm not really too proud of this case, but as you can see, it was really bad placement. I mean, prosthetically with the custom abutment, I made it work, but patient came back in a few times because the screw got loosened, and then the access hole is on the distal lingual side there, and then actually I haven't seen the patient for a while, so maybe it is doing okay now, but it is not the ideal situation you want to be in. So when you place implants, you want to place implants as ideally as possible. It's kind of like if you want to have really good crowns, you want to have really good margins. So you got to have good implant placement. That way you can have good implant prosthetics. So that's just like another digital phase for me, because it was about maybe 4 or 5 years ago I got into I guess implant, digitally guided implant, whatever you call it, and Blue Sky Plan is what I started with, and it was very interesting. And that is my first 3D printer. And then it's Robox is from the Great Britain. It's the I mean, it was okay. I mean, but it was pretty basic. And I don't think anybody still use that printer to make surgical guides. But it was pretty useful too. I mean, it was a fully edentulous case, and I designed basically I converted patients' existing dentures into surgical guides. So I used the Blue Sky Bio and designed the surgical guides. As you can see, I placed 4 implants on the maxilla, and I placed 2 implants on the mandible. And then that's the surgical guide I got from that printer I just showed you. And it looks like not cool, but it still worked. So that was the case. It's basically, it was patient replicas of patients' dentures, existing dentures. And then I kind of marked it, and then, drilled through the tissue. I placed 4 on top and 2 on the bottom, and, it was pretty good. So what are the benefits of guided implant surgery? So, I mean, it will improve the clinical outcomes, and, I think, just sometimes it will increase the patient's acceptance. When I show, I don't do this all the time, but sometimes, when I have the intraoral scans and CT, and if I have time, and I just, work up the surgical plan in the software, and then I present it to the patient, and then most patients get impressed by that. And then I think it would definitely increase the patient acceptance. And then patient can learn, they can see or why you have to do GBR. They'll understand why you have to do sinus graft. And then it also helps you to study the case, more, okay? Because instead of just looking at the panel and say, okay, I'm going to place implants there. I mean, you have to plan it very well so you get to know the case even more. And then basically you're spending more time outside the patient's mouth so that you can spend less time on the patient's mouth. So it will reduce the chair time. So there are some benefits with the guided implant surgery. So it's same workflow. I mean, you gotta have data, and you gotta have the CAD software and CAM software, and you have to make surgical guides. So when it comes to digital implant, guided surgery, data is basically you gotta have CBCT, CT, and patients scan models, digital models, and surgical guide design software and CAM software, and then you can either mill your surgical guides or 3D printing. I mean, 3D printing is more popular the mode of manufacturing when it comes to surgical guides, but you can still mill it too. So what is CBCT? I mean, you know what CBCT is. It's basically CT scan for the mouth, and then once you take CBCT, it will be in DICOM format. So those CT files, it could be in many different format because each CT company have their own proprietary format. But CBCT is more like a universal language. So I'm sorry, the DICOM is more like a universal language. So you can share DICOM, and then it will be read by almost any proprietary software. And so that's DICOM. It stands for Digital Imaging and Communications in Medicine. And another form of data you need is basically STL file. So STL file stands for stereolithography. It's just basically moving files. The JPEG is like a still shot, the still photos. STL file is basically like a video file, not really video file, but it's more like a moving file. So also background is a standard triangle language, and you'll see why it is, its background is standard triangle language there. So this is basically STL file. With this file, you can enlarge it, you can reduce the size, you can rotate it, you can pan it around, so this is basically STL file. And then if you look at it, it's made up of a bunch of triangles. And a bunch of triangles make up this 3D images, or not images, but 3D model, basically. So that's why it's called, its background is standard triangle language there. And then there are other types of files too. STL is like the most common in the 3D file. But in dentistry, we use OBJ and PLY files too. And the biggest difference between STL file and OBJ or PLY is basically STL file does not have surface characteristics such as colors. So STL files don't have colors, but OBJ and PLY files do have colors. So this is OBJ file, same thing. You can rotate it, pan it, move it around, enlarge it, and make it smaller. But only biggest difference is that it has colors. And do you need to have colors? Well, not necessarily. I mean, but I think it is really helpful. And then actually when I marginate a press, sometimes colors make things more distinctive. So it is sometimes easier for me to find the margins when it is color. So I used to use STL files, but these days I usually import OBJ files into the CAD software. So let's look at a case. It's number 3 implant placement I did. So this is a pre-op. Its image is generated from a pre-op CBCT. It's number 3. I extracted the tooth. I usually do extraction and immediate placement, but patient wanted to do in phases. So I extracted and do the socket graft. But the socket graft was not that great. I use a PRF, and I'm sure you guys know PRF and sticky bone from Dr. Charles Park. But I guess the closure was not that great, so I lost some, the graft particles, and so the graft was kind of okay, but it was not that great. But anyway, as you can see, there is not enough, vertical height of the bone. So we have to do some sinus lift. I have about, depending on where you look at it, but about 4 to 5 millimeter of bone height. So this is so i700 software for scanning. So that's the case I scanned. But actually, this was scanned before the extraction, and then I could have gone back after extraction and rescan the area, but I just didn't do that because you can do digital or virtual extraction with the software. When it comes to implant surgical guide design software, there are so many different choices. This is a few I know for sure. Blue Sky Bio, that's what I started with. And these days I use Dentic Guide. It's from Korea. And Exocad, the company, came out with the Explant, which is another software to design your surgical guides. And 3Shade makes their own surgical guide design software. So you can choose, any of them. Blue Sky Bio and Dentic Guide is probably better for the beginners because of its price. It's basically free to download the software. Blue Sky Bio, you can go to their website. You can just download their software. And same thing with the Dentic Guide. Only time you have to pay is if you design a surgical guide in the software, you have to export that design. So when you export that designs from the software, that's when you have to pay. So each export costs about $20. I mean, if you buy big bulk instead of like I used to buy 10 exports at a time, and then it's about to be like maybe $21 per export. If you buy 100 or 200, then it'll be a little cheaper. But anyway, Blue Sky Bio and Dentic Guide are the ones, probably easy ones to get, and you can use Exoplan. It's about like $4,000, I think. Implant Studio, that's probably around that price range. So if you're interested, you can, like I said, go to Blue Sky Bio or Dentic Guide. You can download the software, you can play with it. Let's see. That's the little video on, I guess, how to design a surgical guide. So that's Dentic Guide. So new patient, can put the first name and the last name. New case, and select a tooth. So we're doing number 3. Crown is like a virtual wax up. And now you have to bring in the import the data. So bring in DICOM file, which is a CT. And then I'm bringing the upper scan and lower scan. And then you might wonder, I mean, as you can see, this CT has really great quality. I mean, how come you can't just design guides on CT? I mean, you can definitely see it, but the accuracy of DICOM is not as good as the scans. I mean, I said that scans can be in like 20, 30 microns, but the the CBCT, you know, it's like 100 or 200, even 300 micron accuracy. So you don't want to design something on, you know, model with a 300 accuracy. So that's why you want to stitch, you know, digital scan with the CBCT. So you have to find the basically same spot on the these two images. And this is one of the things that will determine the accuracy of your guides. I mean, you know, you may have really accurate digital model and you may have really accurate CBCT, but if your stitching is, you know, not good, then the outcome is not going to be great. So every step is very important. And you see the green image that those two overlap images are well aligned. I mean, definitely the more green is the better. So I kind of tweaked a little bit to have a little more green. And then you can kind of check manually and see. And then you see the little kind of brown outline. And then if this looks like a really good, you know, stitching there. So that's combining those two data. And then I am doing the virtual extraction, basically. Like I said, you know, I could have scanned, I could have the patient back and scanned the after extraction, but this is easier. That way patient, you know, doesn't have to come back. So you virtually extract the tooth. And now I'm doing a virtual wax up. And like I said, you know, implant dentistry is more prosthetic sometimes than surgical. So you want to have ideal tooth position to place an implant. And, you know, like single implant placement, I can definitely do a, you know, freehand placement, but I just choose to make guides for almost every case. I mean, not 100%. Sometimes CTs are not good, so I can't really stitch images together very well. You know, some various reasons. Sometimes I still do freehand implant placement, but even with the single placement, you know, I try to make guides. And so here I'm just drawing the panoramic line, and I'm choosing the implant, and I use a dentist SQ, and then I'm selecting the diameter of the implant, the length. I chose 5x10, and then, you know, you can use metal sleeve, and then, oh, you don't have to, but I use metal sleeves, so that's the metal sleeve I'm going to use for this case. It's from the dentist. So I'm placing, I'm doing the virtual implant placement here. And then I look at, you know, different things. I want to make sure that there is enough bone on the buccal. I mean, here you don't have to worry about it, but you want to have, you know, at least 2 millimeters of bone circumferentially around the implant. And then you have to think about how deep you're going to place. It depends on how much bone you have, but also how much, you know, tissue thickness you have. You know, there are different things you have to think about when you place implants. So I'm just, you know, checking things around, and then I want to make sure that it's right in the middle of that, you know, the site. And then I'm just adjusting the height of the sleeve. It's because I want to have more material around the metal sleeve so that it could hold that metal sleeve really strongly. And then I'm just drawing the outline for the surgical guide. And then you want to kind of stay away from the missing data. I mean, distal lobe number 2 didn't get really scanned. So the software doesn't like that. this one. Other ones, sometimes it's okay. So that is the surgical guide. And here what I'm doing is I'm trying to create a little viewing window because I want to make sure, I want to visually check that surgical guide is seated all the way. I mean, even if you make a perfectly fitting surgical guide, if it's not seated all the way, the outcome is not going to be as you planned. So I like to have some little windows so that I can see, check, and verify that the surgical guide is seated all the way. And then you can put a little text on it. So I mean, offset is the like the how high or low you put your sleeve there. So you kind of want to remember that, because there are some adjustment you have to make when you pick up your surgical drills. And then when everything is all done and when everything looks good, then you have to approve your design. And then you can export out of this software. That's when you have to pay. And here what I'm doing is that I'm actually designing two guides because I am doing a crestal sinus lift. So I'm not going to place implant like that, but when I initial drill, I want to stop about 1 millimeter short of the sinus floor. So it'll be easy for me to use two different guides so that I can do my sinus lift. I mean, of course, you can just measure the distance, and then you can take PAs to verify that you're how far you are away from the sinus floor. But this could be sometimes easier. So I made two surgical guides, and I don't know whether you notice it, but this one, that circle, the barrel, it's actually taller, because my drill is going to be short of the sinus floor. And then I place the viewing window again, and then approving your design. And then here it will not cost you to export, same case. So it doesn't matter how many cases you do. I think you get charged for just one export there. So I designed it. I 3D printed those two surgical guides, and as you can see, this is for my initial osteotomy to do sinus lift, and this is the for the implant placement. And then it's a little dirty. I mean not dirty, but it has some little supports there, so you can kind of use a little lab burst to clean it. I mean, it's not dirty, just I didn't remove a little supports there. And then surgery, as you can see, the quality of bone is a little poor. Got some lot of tissues there. So that's my first guide for sinus lift. I drilled it, and then as you can see, that's the Schneiderian membrane. And then I use the Densa drill, Densa burst to do the crestal sinus lift. And then using the second surgical guide, I place an implant. And as you can see, there's a little, deficiency of the bone and ridge, so I'm gonna have to graft it again. And then I use this. It's like a healing abutment, but it's not really healing abutment. It's called Santa, and it is developed by Professor Son in Catholic University in Daegu. He's a oral surgeon, and he's he's the one actually who came up with a sticky bone. So anyway, you use it to kind of vertically augment the site, and that's the sticky bone, and that's PRF or CGF pressed. So I put the bone, I put the Santa there, that little healing abutment looking thing, and then the bone there, and then that's pressed CGF or PRF. And then I put little, periosteal, like a stabilizing suture, so that's right. It's kind of hard to see, but enter here, engage the periosteum, and then it's just a little knot in here. And this is a 5-0 resorbable chromic gut. So it will kind of stabilize the, bone and press CGF. And then that's, I think that's still 5-0 chromic gut sutures. And then I just bury it. So that's the post-op image. As you can see, sinus lift looks pretty good. And that's the little Santa. So I guess hopefully I'll get some more bone, especially on the buccal side. And that's cross cut of the implant. And then, I mean, you can definitely see there is no, big sinus perforation, no graft materials, seeping into the sinus. So I think this is gonna be great. I mean, it was done like 2 weeks ago, so I haven't really seen the patient yet. So that's pre-op and post-op. Same thing there. Okay, so I mean, you can use a surgical guide for single case or single double, but you can use it for full arch. I did a couple of cases, and then I, did the whole thing. I designed from the beginning to the end, and I fabricated, different surgical guides for, upper and lower full arch cases. But it's a lot of work. I mean, because first of all, I don't do full arches all the time. Then it was costing me, too many nights, too much time. So for this case, I basically outsourced it. And so there's a lab called N Sequence in Reno, Nevada, and then I think Dr. Pico's in the great oral surgeon in Florida. He, I think, uses N Sequence a lot. So anyway, this is more of the case. So, the dual arch cases and, the same day, I mean, I think the whole thing took me about like 8 hours, It was very grueling and it's like tough day. Because I did my own convergence. If the lab technician did the convergence, then it would have been, a little easier, but I just did the whole thing. So that's the, we call it stackable guides, and then that's fixating in the bone. And then we have to reduce the bone to that level. That's what I did. And then that's a stackable guide to place implants. So it's a really nice system. I mean, this is like maybe case I did about maybe 3 years ago. So back then, there weren't that many labs, who was doing this. But these days, there are so many different labs doing, this kind of stuff. And there's a chrome, guide instead of resin or plastic here. They use chrome, so use metal, so it is more rigid. So you can find more labs started doing this anyway. So place, say, 6 implants and place multi-unit abutments on top of the implants, and then I did the same thing for the lower. And that's the day of surgery after convergent dentures were delivered, and then the patient went home like that. So it would be, if you're doing something like this, it would make sense to do guided surgery. I mean, sometimes it doesn't like fit perfectly, but I still think that it'll be better do it this way than just freehand. I mean, I know there are many surgeons, great surgeons, who these things, are freehand, and the cases are beautiful. So, it is your choice, but since I don't do full mouth cases all the time, I mean, I would guided all the, when I have full arch cases. So that's the panoramic image. So talking about little manufacturing, so there are two types of manufacturing. There's a subtractive, which is milling, and additive, which is 3D printing. So milling is basically like what Michelangelo said, like, when he said, like, when I see a rock, I see, like a human or something. I just carve out the unnecessary part. You end up with a statue like David or other beautiful statues or sculptures. So that's what milling is. Just you saw the Losera case. Designed the crown, and then the milling machine just mill out all the unnecessary part, and you end up with the crown. Additive is basically 3D printing. I mean, the 3D printing is becoming more popular these days. And then this is basically different types of milling machine, and that your labs would probably have. I have actually this one, Roland, 52D is milled zirconia. But, there are so many milling machines out there, cost is about, I would say, 40 to even like over $100,000, depending on what kind of milling machine you get. So going back to 3D printing, which is additive manufacturing, so there are different technology when it comes to 3D printing. The FDM, diffuse deposition modeling, is actually the first 3D printer I got. So basically it works like a hot glue. So there's the reel of materials, and then there's like a little glue gun in this 3D printer, and then it melts that material, and then it just lays, put down a layer upon layers, and that's what diffuse deposition modeling, the stereolithography, SLA, actually I have a printer, the Formlab 2. And then I think the most popular technology is like a DLP in dentistry. And there are other types of the 3D printing technology here. But how do you 3D print an object? So basically, you have an object, and you just slice that object into multiple layers, and then your 3D printer just prints each layer, on top of layer, and then you end up with the same object, 3D printed. So here you can see, thick layers it will print fast, but it may not give you great details. Thin layers, it will probably give you a better resolution, but it will take longer. So on a nutshell, that's the what 3D printing is. This is one of the 3D printer I have. It's the Formlabs Form 2, and now they have Form 3. But in dentistry, I think Formlab and Springray are probably the most popular printers for dentists. But and then these run about like $4,000, $5,000, $6,000. But there are other great printers out there, but they're probably the price is going over $10,000. So you can see that it's the little laser is curing the liquid resin in that tank, and layer by layer, and then you end up with the 3D printed object there. Okay, so let's look at another case. So that's number 19. And then, like I said, one benefit of doing your own, designing your own guide is that you get to study the case more. And then this is like great case. I mean, it's like a mile away. The nerve is like a mile away, and then got a really good thickness there. So same thing, Just kind of fast forward it. We're bringing the CBCT there, and then you're bringing the STL file, or actually OBJ file, because this is, it's color. If we were black and white, then it would have been the STL file. And here, you're just reducing the field of view, because the bigger the field of view, the more data it is. And the more data there is, then it may take a little longer for the software because there's more data. I mean, depending on your computer spec, if you have really good graphic card and fast the processor, then, it may not make a huge difference. But if you don't have, say, gaming laptops or gaming computers, then reducing the FOV might be helpful. And here, you're just just connecting dots, basically. And then after design, I just that's the guide. This is STL file in another software, little 3D file viewing software called Mesh Mixer. I'm just showing you the designed laptop. And now this is basically CAM software for 3D printer, or nesting software. So I brought this STL file into this CAM software for 3D printer. And your 3D printer can't print object like that because you can't have air here, space. I mean, your printer can't just print. So you got to have the supports. So when I said, the guide looked kind of a little, not so great because I didn't, trim off the supports. That's what it is. So these are supports. And because of supports, that 3D printer can print something like that. And then that's the 3D printed. And that's metal sleeve I used. And then this one, I guess I didn't make a viewing window. Anyway, that's the dentist SQ guide, surgical guide kit. And then I didn't remove the tooth yet, but I just did the initial osteotomy right away. I kind of checked the angle, took a PA, and then it's right in the middle. And, I kind of like that. And then now I'm going to take the roots out. So I sectioned the roots, took it out one by one. And there's implant, I place it. It looks pretty good. And then sometimes I check ISQ, the penguin, and then I can't remember the reading, but it was good. Oh, actually, that was 71, so that's pretty solid. So I can place a healing abutment. So once again, there's sticky bone, and then I fill the socket, and then PRF, and I press them, and then poncho technique. The professor Son, he's the one who came up with the poncho, because he was participating in Mexico course by GDIA, and then I think that's where he got the name. Yeah, so the poncho technique. I'm sure Dr. Charles Park, gave you guys a lecture on that one, and then I sutured it, with the chromic cut. Just want to make sure that the press CGF or PRF is pretty stable in the socket. You don't want this this CGF or PRF hanging out of the socket too much there. And that's the after placement. That's there. Okay. And I guess that's another case. It might be the probably last case. Let's see here. Okay, number, it's not 13, it's number 6. It was, I think, These photos were made for, I think it was for the Russian, some online thing. So the numbers are international. It's number 6 and number, I think that's 11. And the 6 has pretty, good amount of bone. And number 11, it's really tight space, as you can see. Crestly, it's only 5.3 millimeter, and then epically, you only got 4 millimeter. So I think I'm planning to place 4 millimeter implant. So it's was really tight, space there. And that's the cross section of number 13. And definitely there's a huge deficiency on the buckle. And number 11 looks a little better, but still it needs to be augmented. And then I blend the case here. And then for number 6, I use sleeve. And number 11, I could not use sleeve because the space was not big enough for the sleeve to be placed. So it's a bit long, so let me cut it short. And as you can see, this is the older version. So this is STL file. Yes, doesn't have any colors. Yeah, stop model there. Okay. And just drawing the outline for the surgical guide. As you can see, that's not a sleeve. It's just a little space, but still it's a little tight. So okay, so that's done, and that photos from the surgery. And there's a guide there, and then I got the little tissue from the tuberosity, and I augmented the buccal side with the tissue there, and then it was like very, very close, and then yeah, I lucked out there. And added some bone, added some connective tissue. And since the stability was excellent, I just placed healing abutment right away. And you can see it's really tight. And number 6, there's huge depression. And then there's a densiber. And for this, I actually used got the block bone. I mean, I just kind of, learning how to do block bones here. So I got the little block bone using the piezo. Okay, and then it's called a split bone technique by Professor Curry. And then I placed the implant, and actually, although you may think that wow, it's like there's no bone there, but if you look at the anatomy of the bone defect, it is very, very preferable for bone formation. So here I did not have to use block bone. I did the block bone just so that I can practice block bone. But here you could have used sticky bone, and then you could have get the same result. So yeah, this is like perfect place with the sticky bone and PRF. And then there's a little, bone block. It's looking a little ugly there. And then that's the actually autogenous bone. I use a scraper and scrape the bone block, and then that's the actually the autogenous bone. And this one I buried it. And that's the harvest. That's the donor site. And that's after the placement. So that's number 6. Got some little screws there, and then that's the Flat bone, very thin. And that's number 11. That's kind of close. I mean, but it's, and then got a little bone there. And then that case is actually restored. So, patient is doing well. So you might question, how accurate is surgical guides? And, there are a lot of studies on it. And then, there are deviation here, like from 0.08 to almost 4.5. So there are deviations, of surgical guides. And then, there's angle deviation, occlusally or mesiodistally. I mean, all I want to say is that, surgical guides don't make, like, they're not perfect. You can make it perfect, but every step has to be perfect. Your CT has to be really, calibrated, up to date, and then has to give you very accurate, DICOM files. And when you scan, you got to have really good scanning skills, and then you have to scan really well, because, same patient, same intraoral scanner, but different operators can yield different accuracies. So even if you have really, the top of the line intraoral scanner, but if you don't scan very well, your STL files may not be accurate. Or if you stitch them together, but if you didn't, stitch them really well, then that could cause accuracy. I mean, the inaccuracy there. Or maybe your 3D printer is not, calibrated, or maybe you didn't nest the surgical guides very well. And, with the surgical guide, there could be errors there. Or maybe during the surgery, you didn't sit the guide all the way. It was not seated properly. That may not yield the good result. So, just it is very, very convenient to have surgical guides. I mean, I love looking at the case, designing the surgical guides, and if I can, I'll do in every case with the surgical guides. But I don't trust them all the time. I use a surgical guide, and I do the initial osteotomy, and then I take a PA, and I evaluate my initial osteotomy. And if I think, and if I see that it is good, then I continue to use the surgical guide until the implant placement. But if when I evaluate the initial osteotomy and it is not what I planned, then I just toss the surgical guides and I go freehand there. So you gotta have solid, solid experience with the free placing implants freehand. Dr. Charles, I don't think he uses surgical guides, but still, he places implants really, really good. I mean, he's a great surgeon, So when you have, good surgical skills and experience, then surgical guides would be very, very beneficial. But don't think that surgical guides will make you do all the cases perfectly, because they're not. So Dr. Scott Gans is one of the big names in digital dentistry. He said that it is not computer guided; it is a brain guided surgery, because it is you that has to determine and decide what to do. I mean, that is your experience, that is your knowledge, everything combined. So digital dentistry, does make you smarter, and that's what I thought. I mean, I thought digital dentistry will make up my shortcomings, but I realized that that's not the case. I mean, you have to be prepared and ready to utilize these technology. So, and here's just a little picture of me, it was in Korea. I was eating crabs, and then and I was a little buzzed, and then I broke my front tooth, and just that is not really brain guided there. You know what? That's 4 months post-op, and then the previous case, remove the screw. You can kind of see the still the bone block there, but the difference is that it looks live. It doesn't look like that piece of bone sitting on top of the ridge. It looks like a vital bone because it is turning over. So that was before. And I place healing abutment. There's one more case. I go really fast. Same thing. Surgery. It's a sinus lift there. Use a dense suburb too. Kind of hard to see, but there's a sinus membrane there. It's Madison bone implant. And I checked the ISQ. That was pretty good. Sticky bone, PRF, and I buried that. And then that was pretty good lift too. 6 months later. And then just a little, I just want to show you how I guess use a scan body. That's upper, lower. That's a scan body. That's from True Abutment. So I don't know whether you are familiar with scan bodies. So scan bodies are basically a digital impression coping. When you take impression for implants, you have to use impression coping. So same thing for the digital dentistry too. So you got to have impression coping. So scan bodies are basically digital impression copies for implants. And scan bodies can be a little confusing sometimes because say, I place dentist implant, but I use a true abutment scan body because there is a company called True Abutment and other many companies out there. They make scan bodies for different implant systems. So here, True Abutment has scan bodies available for dentist implant, or you can get scan bodies from dentist company itself, and then their scan bodies are different. So if you use the scan bodies from True Abutment, then you have to use digital library from True Abutment. And if you use scan body from dentists, then you have to use the implant library from dentists. So basically, if you use a scan body, you have to make sure that your lab, uses the same scan body and has a digital library for it. If they don't, then they may not be able to fabricate the abutments for you. So that's milled zirconia. So there's a crown and there's a abutment, and I use a tie base, and then that's you can see the T. That's a tie base from True Abutment, and then I basically cemented the abutment there, and of course, patient has really heavy bites. You can see that the patient is Korean. And implant, a little, and then implant crown usually has a little narrower occlusal table to reduce the interferences there. And I extraorally cemented so that I could make sure that there is no excess cement on the abutment or the crown. And delivered, and that's the photo. And I guess that's all I have for today. Just wondering if you have any questions.
Are there any advantages of the true abutment over the um, abutments, the scan bodies from the actual companies?
Um, no, not necessarily. The true abutment has, they carry, different, scan bodies or tie bases for different companies. So it depends on, I guess, where you can get, better prices, and or you have to look at their, say, tie bases. Or actually, what you can do is like True Abutment makes the custom abutment. They mill custom abutments with the titanium. So if you're gonna have custom abutments made in titanium, actually, maybe your lab may use a True Abutment. So if that's the case, then you might want to use scan bodies from True Abutment. So it depends on how you or your lab is going to um, restore the case. So once you start with the like true abutment line, then you got to go all the way with the true abutment. If you go with the, say, scan body from dentist, then you have to go with the dentist line. But right now, dentist does not have tie bases, with the FDA approval. I mean, they are in the process of getting the FDA approval, but they don't have in tie bases, from dentist does not have tie bases for their implants. So if you use scan body from dentist, but if you want to use tie base, then you're stuck because you don't have tie bases. Does that answer your question?
Yeah, it does. Thank you.
Okay. If you have any more questions later on, this is my email and my cell phone number. You can, contact me anytime. Thanks for watching me, and I hope you guys have a great weekend, and hopefully someday our paths will cross. Okay? All right. Good night.